Hi, my name's Andrew, and in this session we'll be going over hemolysis, the premature destruction of red cells, why that occurs, and many of the important tests that we can access as clinicians when assessing whether there is evidence of hemolysis and what the potential causes are. So let's go over some basics of hemolysis. The first thing is the definition, which is it's anemia due to premature destruction of red blood cells. You don't actually have to have anemia to have hemolysis, but for it to be clinically significant and worth potentially treating, there needs to be anemia. Otherwise, the body's just compensating and it's probably not a big deal. The approaches to thinking about or categorizing hemolysis, you can think about whether there's a problem external to the cell or a problem internal to the cell, and we can define that as intracorpuscular, that's the internal issues, or extracorpuscular, referring to external issues. You can think about whether it's immune-mediated destruction or whether it's more mechanical or non-immune mediated destruction, or that can also be from internal issues. And you can think about where is the destruction occurring? Is it occurring intravascularly or is it occurring extravascularly? And there's certain tests and features as well as causes that will fit into those categories. And in terms of investigations, you can kind of think of them being, firstly, is there evidence of anemia? Otherwise, even if there is a little bit of hemolysis, it's not clinically significant. And then we can think about there being features that are evidence of hemolysis as the cause of the anemia. And then there are specific tests that you can order to determine the potential or likely cause of that hemolytic anemia. Here's a diagram that I keep coming back to in my mind when I think about hemolysis. So we've got a red cell that is hemolyzing. I can kind of think of it like it's exploding. And then you can see in the bigger box, the red one, that these are tests that provide evidence that there is hemolysis. So obviously there's anemia, and whenever there's anemia, there'll be a response for the bone marrow to produce more healthy cells. And so those immature cells get released rapidly, and you get a reticulocyte rise or reticulocytosis. So that's just a feature really of acute anemia. It's not super specific to hemolysis, but it's there nonetheless. Then the things that are a bit more specific to hemolysis is the release of free hemoglobin. Usually red cells at the end of their lifespan get recycled and kind of taken apart, typically in the spleen. And when that happens, you don't get release of those elements that are inside the red cell to be detectable in the bloodstream because they're contained within the spleen. So for there to be particularly intravascular hemolysis, there is a release of free hemoglobin. You can do tests to identify that, but we don't use those tests very often. Most of the time we actually use cheaper tests such as haptoglobin, which is a globulin or protein produced by the liver to mop up free hemoglobin because it's a very reactive kind of molecule that the body would like to get rid of before it causes problems. So if there is free hemoglobin, the haptoglobin will actually be consumed by eating up the free hemoglobin. So it should be undetectable. If it's just slightly reduced, there may be other causes for that, particularly liver disease. But if it's undetectable, that's quite specific and sensitive for hemolysis. The other one is that as the heme degrades down, it will form bilirubin, the yellow stuff that we see that causes jaundice. So if there's a bilirubin rise, that can often be due to hemolysis. Lots of other causes too, but hemolysis is definitely one of them. And then a more generic and non-specific but still sensitive sign of hemolysis will be a rise in lactate dehydrogenase, which is an enzyme that's present in most of our human cells. And so to see generically cellular turnover, including red cells or cancers and others, that will be on the rise. So we'll see it risen in the context of hemolysis too. Then there's two sets of tests that really tell us about the cause of hemolysis. And one of them that is both evidence of hemolysis and potentially telling us the cause are the blood film features. And that's when a scientist, technician, or hematologist looks down the microscope at the blood film. There are features that can tell us that there is hemolysis and give us hints to where that hemolysis is coming from in terms of the cause. That's really helpful. We'll talk about those specifically in a moment. And then lastly, a test that just tells you about the cause and isn't necessarily evidence of hemolysis itself is the direct antiglobulin test, or DAT. This used to be called the direct Coombs test, but we've moved away from naming things after specific people as it doesn't actually describe what the test is. So this is an easy one. It's a direct anti-hemoglobin, that's the globulin part test, or DAT. Before we get onto the blood films, let's talk a bit about causes. We can split them into these 5 different categories. Firstly, congenital. So quite a lot of famous hemoglobinopathies are listed here: thalassemia, alpha or beta, sickle cell anemia, G6PD, which is glucose 6-phosphate dehydrogenase deficiency. That's where you've got an enzyme that's missing that usually protects the red cell from oxidation, and therefore when there are triggers for oxidation, and the classically described one is broad beans, but there are a number of antibiotics including gentamicin that can trigger this, you will then get a sudden trigger of hemolysis because there isn't the G6PD that's present in most of the population protecting the cell from that trigger. And then there are other hereditary causes as well, like spherocytosis and other conditions. Then there are non-immune. I think of these as being kind of mechanical shredding or reasons for the cell to be destroyed that are not the immune system attacking it. So there can be thrombotic microangiopathies, and that's where there is clots. So that's thrombotic, which is clots. Microangio meaning small vessels, pathy meaning disease. So it means there's clots in small vessels, and when that happens, the actual red cell, as it goes through that very narrow tube with the bits of clot, is literally shredded into pieces, and so that's a cause for intravascular hemolysis. Those include disseminated intravascular coagulopathy, or DIC, thrombotic thrombocytopenia purpura, or TTP, and hemolytic uremic syndrome, or HUS. There are others, but they're the big 3. Then if you've got a mechanical heart valve, and particularly if it's an older style one or it's not seated really well, they can cause non-immune hemolysis. Malaria can grow inside red cells and then destroy the red cells, so that causes a mechanical hemolysis. And then there can be spur cell anemia, which is usually related with advanced liver failure, and cirrhosis, usually a very bad sign and one that is often irreversible without a liver transplant. Then there's autoimmune disorders, so you just think autoimmune hemolytic anemia, or AIHA. The classic description for that sits under warm hemolytic anemia. Then you can get cold forms as well, so there's cold agglutinin disease, and that can often be secondary to other issues like infection or drugs. And then there's also paroxysmal cold hemoglobinuria, or PCH. Then there are transfusion-related hemolysis conditions, so these acute or delayed transfusion reactions. And then there's drug-induced hemolysis, which can be specific drug effects, or it can be G6PD related, or rarely it can be DITMAR, which is drug-induced thrombotic microangiopathy, a much rarer condition, but a serious one nonetheless. So they're the causes that we think about when we are thinking about hemolysis. Blood film features, like I mentioned before, are really helpful as evidence of, but also likely pointing to the cause, which is great. So we can see here schistocytes, fancy words for fragments. So on the top left corner there, you'll see there are some that where it's like the majority of the circle is still there, but there's one flat end where a fragment has come off. And you can see in the middle there's a piece of a red cell, that's the fragment. So the schistocytes are kind of the fragments, and you can see the helmet cell is where you've got most of the cell plus a bit missing with a flat end, so it's like a helmet. So those are classically seen in microangiopathic hemolytic anemia. So like we said, small vessels where because of clotting those red cells are shredded, and so you see the bits of the shredded and the remainder of the cells floating around on the blood film. You also may see spherocytes and elliptocytes. They're associated with autoimmune hemolytic anemia. So as those antibodies latch onto the red cell, and then the immune system will actually take away part of the cell can then reform into unusual shapes, spherocytes and elliptocytes. You can also see features, so the bottom left one is red cell agglutination. So you can see how those red cells are clumping together, and that generally improves with warming. We often do a colder film and a warm film, and the warmer film looks better and clearer, and that confirms red cell agglutination. And we see that in cold agglutinin disease. So that's where there are these antibodies that have a different thermal amplitude, and so when they get cooler, the antibodies become more active and effective, and when it gets warmed to full body temperature, the antibodies are more inert. Then you can see acanthocytes, they're spur cells, which are found in liver failure, so spur cell anemia. You can also see blister or bite cells related to oxidative damage like G6PD deficiency. And then you can see actual sickle cells, which of course related to sickle cell anemia. So lots of real richness of information that we can glean from the blood film. Let's talk a little bit more about the direct antiglobulin test. As I said previously, the direct Coombs test. So we use this to determine, are there antibodies directed against the red cell surface present in that patient's bloodstream? And it's really important that we interpret this firstly by saying, is there hemolysis? Because if there is definitely hemolysis, a DAT test is a really important next step to determine, is the hemolysis immune mediated or not? If you test DAT and it's positive without features of hemolysis, it's not really interpretable in that context. Basically, the DAT test will be positive for IgG or IgM, but we don't directly measure IgM, and so we use complement as the surrogate marker for IgM. Things that are warm mediated are generally IgG mediated, and those that are related to cold conditions are generally IgM mediated. So therefore, if it's IgG positive, that would point us towards a warm autoimmune hemolytic anemia. And if it's complement positive, that's a surrogate for IgM, it is likely a cold agglutinin mediated disease or another within the cold family as well. If you have both of them positive, so complement and IgG positivity, it more points to us seeing a mixed autoimmune hemolytic anemia picture. So there may be more than one process going on, or it might be just an unusual manifestation of one cold or warm. Then if it's negative, it's very, very unlikely to be immune, and we generally look for non-immune causes in that case. However, it's important to know that 5 to 10% of autoimmune hemolytic anemias are DAT negative. So just bear that in mind. But I personally haven't seen any cases that we've been confident or confirmed is AHA that didn't have a positive DAT. So it's a pretty reliable test. Then you can have these false positive results, which I alluded to before. That's when you get a positive DAT, but there is no actual evidence of hemolysis on the blood film or the testing that we've done. That can happen because they are receiving supplemental intravenous immunoglobulin or IVIG, or they're receiving Rhesus-D therapy, or if they've received anti-thymoglobulin, which is an ATG, an anti-T cell therapy. Can also happen with certain antibodies like daratumumab, which we use for myeloma. And if you've had a recent transfusion, you can develop these allo antibodies for a time that will persist, and they can give you a positive DAT as well without any hemolysis. And then some people, just in the course of sepsis and having a large immune response, will have a positive DAT even though there's no hemolysis. So particularly ICU patients, if you were to test DATs on all these ICU patients with infection, you'd find a decent proportion of them are positive, but almost none of them have any hemolysis. So it's good to think about, what if it's not hemolysis? What else could be causing this anemia or these other tests? And these are calls that we get as the consultation service for hematology, asking these questions where there's been some testing done looking at the question of hemolysis, which is not consistent with hemolysis. So what are the other differentials to consider? So obviously an acute anemia, always think about blood loss. Always think, especially in very unwell people where it's maybe more subacute, think about bone marrow failure. And also to think about sometimes anemia is artifactual, so the actual test itself is inaccurate. And so if you're seeing a sudden test, a sudden drop on one test from one day to another that's not explained, just repeat the test and you might actually find that that's an artifact result. Also, if you've got decreased haptoglobin, which is a very specific test for hemolysis, the next most common cause of that is liver disease. So do they have a history of that? Are their liver enzymes raised? Those are questions you can look at and think about, is there liver disease that is causing this decreased production of haptoglobin, therefore decreased total haptoglobin? If it's completely non-detectable, then it's probably hemolysis. But if it's just reduced, it's probably more likely liver disease. What if you have a raised bilirubin? Well, we're getting a bit more broad now. Of course, liver disease and of course biliary obstruction from cancer or stones, cholelithiasis. And then lastly, even more generically and more broad, is increased LDH, a generic cellular turnover marker. Think about infection, think about malignancy. Many different cancers can cause this. Think about myocyte injury. So if you've got rhabdomyolysis, for example, pregnancy, surgery obviously has to be very recent, infarction of tissue, particularly a myocardial infarction, and vasculitis. These can all cause damage to a lot of cells quite suddenly and a release of LDH. So coming back to this diagram, think about these tests in the red as being evidence that there is hemolytic anemia, and the ones in the blue are giving you ideas and likelihood over the cause of that hemolytic anemia. Important to realize that the DAT does not tell you there's hemolysis, it tells you whether there is a likely immune-mediated hemolysis if you've confirmed the hemolysis first. So I hope that's helpful, and thanks for joining me.